Welcome to the Indian Council of Medical Research online prescribing course 2020 for the Indian medical graduate. I am Dr. Ratinder Jhaj from AIIMS Bhopal, and today I am going to talk about prescribing in ENT disorders. After this video, please access the multiple choice questions and submit your answers. These can be found in the assignment section. My co-authors for this video are Dr. Ajay Shukla and Dr. Balakrishnan, both pharmacologists from AIIMS Bhopal, and Dr. Vikas Gupta, who is an ENT specialist in AIIMS Bhopal. This video has been reviewed by Dr. Pooja Gupta from AIIMS New Delhi. At the end of this module, you will be able to prescribe rationally for a patient with either of these common ENT conditions, that is acute otitis media, acute tonsillitis, allergic rhinitis, acute laryngitis, which I will be covering through this lecture. Information about acute sinusitis has been provided separately as part of the reference material. You will also be able to communicate to a patient information and instructions regarding prescribed medication in simple language that he or she understands. And perhaps most importantly, you will know when to refer the patient for specialist care if necessary for further management. Each condition will be covered with the help of a case scenario, followed by brief information about the condition, key points in management, prescription for the case, when to refer, important do's and don'ts. In the end, I will also show you some reference and reading material. Let us start with the first case, who is Om, a 3-year-old boy brought to the OPD by his mother with complaints of running nose, cough, crying and pulling at his right ear for the past 2 days. On otoscopy, there is marked arrhythmia and bulging of the tympanic membrane of the right ear. What will be your tentative diagnosis? Now, this is a case of acute otitis media. I hope you can appreciate the bulging and arrhythmia of the tympanic membrane in this picture. Now, how did we arrive at this diagnosis? For that, let us go over some salient points about acute otitis media. Acute otitis media is a common illness of childhood. It is defined as moderate or severe bulging of tympanic membrane, or new onset otorrhea not caused by otitis media, or mild bulging of tympanic membrane with recent onset of ear pain or arrhythmia of tympanic membrane. Characteristic signs and symptoms of acute otitis media are otalgia, fever, thickened or bulging tympanic membrane, hearing loss or otorrhea. So, coming back to our case, Om, the little boy, had crying and pulling at his right ear since 2 days. Now, this is indicative of ear pain. On otoscopy, we found there was arrhythmia and bulging of the tympanic membrane. So, we can make a tentative diagnosis of acute otitis media. Having diagnosed the case, now we need to manage the patient. In management of acute otitis media, the first thing is pain assessment and relief by using paracetamol or ibuprofen or any other NSAIDs. Next, we see if any of the 3 are present, that is otorrhea, bilateral acute otitis media in a child less than 2 years, or severe disease which is defined as temperature more than 39 degrees Celsius, or severe otalgia or otalgia persisting for more than 48 hours. If it is a yes to any of these, antimicrobials are definitely indicated. Otherwise, we can choose for watchful waiting for 48 to 72 hours, or we can still use antibiotics upfront. Having decided to use an antimicrobial, the next question in your mind will be which antimicrobial to use. If a patient has not received penicillin in the past 1 month, we can prescribe amoxicillin. But if the patient has received penicillin in the past 1 month or there is no response to amoxicillin in 3 days, amoxicillin clavulanate is recommended. If the patient is allergic to penicillin, then we can use azithromycin. Duration of any of these drugs is between 5 to 10 days. So, now let us prescribe for a patient who is a 3-year-old boy with acute otitis media. For pain relief, we can give him syrup paracetamol 5 ml per mouth as and when required to relieve pain in the ear. Remember, paracetamol, though a very well tolerated drug, is dangerous in overdose. So, it is very important to give an instruction to the patients or to the parent
that they should wait at least 4 hours before giving another dose, and also they should not give more than 4 doses in 24 hours. Dose calculation for paracetamol has been explained in the reference material. As I said earlier, we can choose to give an antibiotic upfront, in which case it can be syrup amoxicillin, because in this boy there was no history of giving penicillin in the past 1 month. So, we can give syrup amoxicillin 5 ml by mouth 3 times a day for 7 days. We should advise the patient to follow steps on the packing to prepare the syrup and also to shake the bottle well before use. India is a country where a lot of home remedies are common. So, therefore, it is very important to advise the patient not to use home remedies like hot oil or water for acute otitis media, which is often done. Also, do not forget to ask the parents to bring the child back again if there is no improvement in 3 days. Otherwise, they can bring back the child for review after 7 days. For any disease, besides knowing when and how to treat, it is very important to know when not to try to treat and instead when we should refer the patient. In case of acute otitis media, this is in case of severe disease, which we have already defined, or if there are persistent symptoms despite 48 to 72 hours of antibiotic therapy. So, having treated little Om, now let us go to another patient in our OPD, who is a 7-year-old boy who has been brought to the OPD by his mother with complaints of pain in throat during swallowing and fever for the past 3 days. Throat examination shows erythema of tonsils and posterior pharyngeal wall. What will be your tentative diagnosis for this case? This is a classic case of acute tonsillitis. In this picture, you can see the erythema of the posterior pharyngeal wall. To go over very briefly some salient features of acute tonsillitis. Acute tonsillitis is an inflammation of the tonsils, usually self-limiting. It often affects school children but also adults. It is rare in infants and persons more than 50 years of age. Acute tonsillitis is usually an infection. It can be viral or bacterial. Viral infections are more common, especially in children less than 5 years. Bacterial infections are typically due to group A beta hemolytic streptococci, which we also call GABs, which can lead to rheumatic fever and glomerulonephritis. Classic signs and symptoms of acute tonsillitis include fever, malaise, sore throat and pain on swallowing. On examination, we usually find erythema of tonsils and posterior pharyngeal wall, enlarged tonsils and tonsillar exudates. Tender upper cervical lymphadenopathy may also be present. The last two, that is tonsillar exudates and presence of tender upper cervical chain lymphadenopathy, are indications which lean towards a diagnosis of GABs. So, looking back to our patient, the boy had fever and sore throat and pain during swallowing. Also on throat examination, there was erythema of posterior pharyngeal wall. So, we can make a tentative diagnosis of acute tonsillitis in this boy. Once we have diagnosed acute tonsillitis, there are certain criteria called Centor criteria which help us to identify the likelihood of GABs infection and to decide whether we should use antimicrobials. For this, we look at 4 clinical features: fever, tonsillar exudate, anterior cervical lymphadenopathy or absence of cough. We give 1 point if any of these features are present. If the total score is 0 to 1, it is very unlikely that GABs infection is present. In this case, there is no need to give antibiotics and the patient can be managed symptomatically. If the score is 2 to 3, it is possible that there is a GABs infection, but before we start antimicrobials, we should send the throat swab for culture or antigen testing, and only if it comes positive we should give antimicrobials. On the other hand, if the score is 4, then we can start antibiotics immediately after sending the throat swab for culture or antigen testing. Symptomatic management of acute tonsillitis involves analgesia and antipyretics, for which we can use paracetamol or ibuprofen or any other NSAID. We should also advise the patient complete rest, plenty of fluids, a soft diet and topical soothing measures, which could be sipping cool or warm liquids. If an antimicrobial has to be used, Since GABS is the most common infection, oral amoxicillin or penicillin V for 10 days are the recommended antibiotics. In case of penicillin allergy, we can use oral azithromycin, which needs to be given for only 5 days. Now, if a patient has GABS, we know that GABS sore throat can lead to complications like rheumatic fever and glomerulonephritis. Therefore, it is very important to advise and adopt infection control measures. For the patient and guardian, we should advise that the child should not be sent to school till at least 24 hours of antibiotics have been taken, because the child may infect other students. Similarly, the child should avoid going to other crowded places. In addition, we should educate the parent about cough hygiene and maintaining good hygiene such as frequent washing of hands. You as a healthcare worker should use standard and droplet infection control measures. Now, coming back to our case again, our case has fever and there was no history of cough. So, the center score is 2. So, what do we do for this case? We need to send a throat swab for culture and give supporting measures, that is, give syrup paracetamol 5 ml per mouth as and when required to relieve fever. Do not forget the precautions about paracetamol dosing that we have already discussed. We can ask the patient to bring back child after 3 days if there is worsening or if the symptoms persist beyond 3 days. Now, if the throat swab comes positive for GABS, we need to add oral suspension amoxicillin 10 ml by mouth 2 times a day for 10 days. When should we refer a patient of acute tonsillitis? This is true if there is any concern regarding airway compromise, for example, stridor, drooling or respiratory distress, because remember, sore throat can be a symptom of serious upper respiratory tract conditions like epiglottitis or supraepiglottitis. Therefore, if there is any concern about airway compromise, we should ask for an ENT consult immediately. Now, let us go on to another case. This is an adult who presents with complaints of sneezing, rhinorrhea and itching of the nose for the past 2 years. He says that his symptoms worsen during the winter months, that is December to March, particularly when he goes for a morning walk to a garden in his colony. What will be your diagnosis now? This is a classic case of allergic rhinitis. What is allergic rhinitis? It is an allergic inflammation of the nasal airways. It may be intermittent or persistent. Allergic rhinitis is characterized by bouts of sneezing, rhinorrhea, nasal obstruction and itching of the eyes, nose and palate. It is frequently associated with postnasal drip, cough, irritability and fatigue. Coming back to our case, this man had sneezing, rhinorrhea and itching of the nose, and his symptoms were worse during the winter months, especially when he went for a walk to the garden. Now, in many parts of our country, winter is a time for winter flowers. So, it is possible that he suffers from intermittent allergic rhinitis due to an allergy to pollen. How do we manage a case of allergic rhinitis? Allergen avoidance is the most important step to manage allergic rhinitis. For outdoor allergens, we can decrease exposure to allergens by avoiding going out during the pollen season. For indoor allergens, to avoid collection of dust mites, we can cover mattresses with impermeable covers. We can wash bed linen in hot water every 2 weeks if possible. We can advise the patient to avoid exposure to pets and to maintain proper ventilation in house to avoid dampness in the house. Coming to the pharmacological therapy or drug therapy of allergic rhinitis, oral antihistamines are the first line of drugs for treatment of allergic rhinitis. We can use drugs like phentermine or the non-sedating or less sedating newer antihistamines like cetirizine or fexofenadine. Intranasal steroids like fluticasone, mometasone, budesonide may also be used along with oral antihistamines. In fact, they are preferred therapy in patients with persistent allergic rhinitis. So, now let us prescribe for our case of allergic rhinitis who is a 30-year-old adult. We can prescribe 1 tablet of cetirizine 10 milligram to be taken by mouth once a day for 7 days. We will also advise him to avoid going for walks in the garden during winter months, and ask him to come for follow-up after 7 days. If symptoms persist after 2 weeks, we may need to refer him to an ENT specialist. Now let us come to the last case for ENT today. Now this is a 45-year-old physics professor who presents with history of dry irritating cough, hoarseness of voice and pain in throat, particularly after talking for the last 3 days. He does not smoke or have alcohol. What will be your diagnosis for him? This is a classic case of acute laryngitis. Acute laryngitis is the most common cause of hoarseness of voice. It is a self-limiting condition usually associated with viral upper respiratory tract infections or acute vocal strain. Clinical features include hoarse voice, pain in throat, particularly after talking, dry irritating cough which is usually worse at night and may prevent a patient from sleeping soundly. So looking at our professor again, he is a physics professor, which means he may need to deliver lectures like I am doing right now. He has dry irritating cough with hoarseness of voice, particularly after talking. So we can make a diagnosis of acute laryngitis due to vocal strain. Acute laryngitis resolves with symptomatic treatment. Symptomatic treatment involves voice rest, hydration and humidification of the larynx with steam inhalation. Antibiotics are not effective in treating acute laryngitis, and that is an important point to remember. Smoking and alcohol should be avoided. So now let us prescribe for our patient of acute laryngitis who is a 45-year-old male. We will advise him to take complete voice rest. If he has to speak, it should be in a soft sighing voice and he should avoid whispering. It is interesting to note that whispering actually adds strain to the larynx. So the patient has to be advised to avoid speaking or to speak in a soft sighing voice. And since he is a professor, complete voice rest may involve having to take leave. We also advise steam inhalation 2 times a day to clear secretions, and if symptoms do not resolve after 2 weeks, we will ask him to come back for re-evaluation. If this hoarseness persists for more than 2 weeks, we will need to refer him to an ENT specialist. So there are some important don'ts for acute laryngitis. Acute laryngitis, as we have already seen, is usually either a viral infection or caused by vocal strain. So unless there are clinical features which are suggestive of a secondary bacterial infection like fever or toxemia or purulent cough, we should not prescribe antibiotics for acute laryngitis. In fact, I am ending this module with an emphasis to avoid unnecessary use of antibiotics. This is some reference and reading material which you may find useful. I have included this in the additional reference material which you can download as a PDF. I would like to thank all members of the RUM committee AIIMS Bhopal and my co-authors Dr. Balakrishnan, Dr. Ahmed Najmi, Dr. Ajay Shukla, Dr. Shubham Atal. I would also like to specially thank our interns Dr. Mridula Chain and Pratyush Prateek, who were helpful in going through the pilot of this module. Thank you for watching this video. I hope now you are ready to prescribe for some common ENT conditions. Please do not forget to download the MCQs, solve them and submit them. Please also complete the prescription evaluation as per the tutorial. I hope you have already seen that. Thank you and happy learning.